If I've learned anything in being a therapist, if you can connect with a patient on what they truly believe and want, not what you think they should do, but what they think they should do, then their compliance, their outcome, their belief in how well they're doing will 100% go along with what their psychology is.
Welcome to UpMed, a journal of healthcare's race to the bottom, hosted by Dr. Rowe Urquhart. Join Dr. Erica and her guests as they pull back the curtain and share a behind-the-scenes look at the healthcare industry, all while providing solutions for better patient care and management. Now, here's your host, Dr. Erica.
Hello, and welcome to UpMed, a journal of healthcare's race to the bottom. I'm your host, Dr. Rowe Urquhart, and I have the esteemed pleasure of being with a very good friend and colleague of mine, Dr. Gargiulo, who is a doctor of physical therapy. Welcome to UpMed, Dr. Gargiulo.
Thank you, Erica, and thanks for inviting me. I'm really excited to be here.
So, if you don't know, here in New Jersey, Dr. Gargiulo is kind of an institution on the other side of the Hudson River. He started in 1977 after completing his Bachelor of Science in Physical Therapy at New York University in private practice in Jersey City, New Jersey, where he began offering physical therapy services in the private practice setting. Then he completed his master's degree in kinesiology, also from NYU, in 1982, and then chose to go back to school for his doctorate at Rutgers University, physical therapy. That was in 2005. Dr. Gargiulo is well published and, as I said, well established here in northern New Jersey. And his most recent job title is Regional Director with Twin Borough Physical Therapy, which he has been in that position since 2020, the beginning of the COVID pandemic.
Yes.
So, Dr. Gargiulo, welcome. I guess that's a great place to start. How was it that you ended up working with Twin Borough Physical Therapy and becoming their regional director at the onset of the COVID pandemic?
So we actually knew Twin Borough way back from the days they were actually Twin Borough. They had two offices, and they were in Union and Roselle Park.
Okay.
And from that point, I knew the original owners who are not at Twin Borough now. And we gradually developed a relationship with them, just basically academically. We had interests in certain subjects. One of their principals was Wayne Rath, who was really a very strong authority on back pain, treating back pain with the McKenzie method, which I can go into, and you and Mark know about that method. And got to know Twin Borough. So over the years, we sent many patients to Twin Borough from this area. As they expanded, they began to grow and add offices and grow throughout New Jersey. We stayed in Hudson County and they grew. So things changed over the years, but we continued to have a friendly relationship. Well, lo and behold, I'd say about 4 years before I joined them, they had a CEO who was actually running the company. And he came to me and he indicated that they were growing and always wanted to be in Hudson County. He said, but we would never come into Hudson County unless you joined us and became part of our company. And at first I said, oh, no, we're independent. But as I looked at their platform and the things they did, I saw that it was a great clinical company and patient-centered like us. And we had sent many patients to them over the years who had good things to say. Lo and behold, in 2019, we decided to join forces and I became part of their company. And they made me the regional director for my area in Hudson County. And they have other regional directors in other areas. And just so happened that was maybe 6 months before the pandemic started. So we had great support through the pandemic with Twin Borough. They kind of guided us, helped us, and here we are today with them.
That's phenomenal. And I think it's such an interesting story because you now have two perspectives. You have the perspective of maybe a more leveraged and corporate physical therapy practice versus a more private and autonomous physical therapy practice. And I don't want you to say anything that you don't feel comfortable saying, but from a high level view, for those of our listeners who may not appreciate how significant that transition actually was, maybe you could just give us some insights to say, these are the bullet points of what private practice looks like in therapy, and these are the bullet points of what a more corporate practice of physical therapy looks like.
That's a great summary of what I'd like to a point I'd like to bring out about the similarities and differences. I think the biggest caveat with corporate work is accountability.
Yes.
Now, when you're in private practice, you're accountable to yourself. You're accountable for the bills, you're accountable for the payroll, you're accountable for compliance, you're accountable for everything. But sometimes that's a good thing, and sometimes that's not always a good thing. I think in the corporate world, because it stretches across multiple locations, there's a more structured accountability platform. And with that being said, I think it kind of forces a provider or practitioner like myself to do, in some ways, a better job and a more organized job in making sure things are taken care of. That's not to say that you don't do it in private practice, but that's to say that when you're accountable to others, you have to do it, and you have to do it right, and you have to do it right away. So I think that's the accountability part is the biggest difference.
I think that's so insightful, and that's only something you would know being in that environment. And maybe just to take a step back so that, again, all of our listeners understand. So you could think of what we're speaking of as, say, the difference between owning your own coffee shop or having a coffee shop that then becomes a part of a franchise like Starbucks. So with Starbucks, when you get a white chocolate mocha at the Starbucks where I live in Montclair, it's going to look exactly the same in theory as the white chocolate mocha that my mother gets in San Diego, California. Where if you have your own coffee shop, depending on who is there, your white chocolate mocha may or may not be exactly the same at 9 a.m. as it is at 9 p.m. The controls just aren't the same as in a corporate environment. So I guess that, is the analogy maybe to bring to the forefront. Do you think that's fair?
I think it's very fair. And I think in healthcare, that could be misconstrued as someone thinking, well, that means that there's not freedom in providing therapy, which there is. Every therapist has, his or her own way of doing things. So that freedom is preserved. But to your point, which is an excellent point, the corporate compliance with things like patient patient follow-ups, patient contact, documentation that goes out, billing standards that go out. That's exactly that. When I said accountability, it's also consistency in operations that actually helped us become a better practice in many ways. There were things that I could have done for the last 30 years that I say now, gee, why didn't I do that? Because I didn't have that structure across the board of all different offices that were doing it. So that is exactly what has helped us in many ways. And it's been sometimes difficult, but it's been a good thing. And your point is a good one.
Excellent, excellent point. So as we're sort of talking about the benefits of corporate, benefit of corporate that I became familiar with, I guess about 2 years ago now, was this platform that you have at your disposal where patients actually are given a username, a password, and therapy protocols, and they have on demand videos and instruction, and also a way of sort of checking that they're doing their exercises either on their phone, their tablet, or their desktop. Would you mind speaking a bit about this integration of technology into maintaining patient adherence to the prescriptions that you're giving for physical therapy?
Well, absolutely. One of the things that impressed me when we joined Twin Borough is that embedded in their medical record was a exercise platform called MedBridge, which all practices can have access to MedBridge. But the key thing that I thought was great with the way they did it is they integrated it directly into Raintree, which is a documentation program. And with that, you could directly from the medical record access the home exercise program, which also had educational materials and compliance materials. You could provide that to the patient and text or email them the exercises and videos. They had a record that if they chose to do it through the platform, we could actually see what they were doing and they could communicate back to us. And that goes out throughout the life of their time with us. So that as you change exercises, as you change routines, that continues to be in their library. And on top of that, there's a Raintree Connect in the medical record that actually lets us text patients on a platform and just kind of interact with them, see how they're doing, let them know, your feedback on how they were doing that day, a summary of their visit. So that integration, which was pervasive throughout the whole company, was something I was very impressed with and happy that I could actually provide better patient care.
Awesome. And have you found that patients are willing to engage in the platform? And if so, do you see a stratification amongst age groups?
That's a great question. I think that getting patients to comply with exercise programs is always an issue. There's some studies out there that says it's not a high compliance rate and a high consistency rate. And I think it varies based upon the patient's need, concern, and worry about where they are in terms of their care. But if it falls on the provider to continue to make that interesting, innovative, and attractive to the patient to continue with it. So I think that patients can easily lose interest if it's not updated regularly, and the platform allows us to update this and keep them compliant. And invariably, the patients that perform things on their own are the ones that do better all the time.
Okay. And do you find that, say, we'll go to Gen X, Gen X versus Boomer, and then I guess on the other end, I guess we'll go to Millennial. We won't go any younger than that. Do you find
Yeah,
that there's a difference with those age groups in terms of
yeah,
utilization, et cetera?
I think the baby boomers are a little bit more compliant, rule following, and the younger generations, I think they kind of have interest, but then they'll go to YouTube, they'll go here, they'll go there, they'll go looking for other things. They come back with other questions. Where as the older generations of the baby boomers are very, very loyal to
Okay.
your advice, and the
Oh,
younger generations they're more versed in what's going on out there. And both of them have their challenges, and it's up to the therapist to win them over and keep them adherent to their plan of care, which is just a quick transgression of that.
hmm.
At Twin Borough, I find them more consistent on making sure a patient completes their plan of care because I think it gives them better outcomes across the board. When we were in private practice, sometimes patients would drop off, sometimes we would lose patients for reasons we didn't know, and the follow through and consistency wasn't as great as it is now. But that's because of the technology, the medical record, and the communication we have with them.
Wow. And that brings me to another point because I'm becoming more and more of a capitalist where healthcare is concerned. And so I have to ask where the dollars are. And one of the questions I have for you is in this environment where you have distinct groups of patients, patients who maybe have government backed insurance, patients who have employer funded insurance, and or privately funded insurance, do you find that in general, their patients are paying about the same amount for their physical therapy out of pocket? Or are there differences there in terms of what each therapy visit costs, say for the private payers, the employer funded, or the government backed insurance?
Well, that's huge issue. The commercial insurance plans have a wide range of patient responsibility. So much so that some employers may choose a low-cost plan to the employer that puts a lot of the burden on the patient. And a patient thinking they have insurance with a commercial insurance literally has a copay that's almost the full amount of our visit, and or a deductible for outpatient services. And that has impacted on a patient's ability to have the funds to complete a plan of care that we think is necessary for them to get the desired outcome for a disability or an injury they may have. I think the government plans are more narrow, like Medicare is a 20% copay and Medicare fees are set, so they're not going to have that excessive cost. And even the Medicare HMOs, they have variable plans where there's some copays as well. But the government plans do not have that wide range of variability of patient responsibility that commercial plans have. And that has been the saddest thing to see, is when someone, for example, has an ACL surgery. Now they're going to need 2 or 3 months of intense therapy. And then they find out they have a $60 copay and they have to come 3 times a week. So they can't afford it. So
Yes.
it's a challenge to work that out with them.
Yes. So that is fascinating, and this is something that in our practice we try to help our patients with, and have actually had great resistance from the private insurances. So for patients, when you have this agreement with your health insurance provider, you should have at your disposal this document, which should be a multi-page document called a summary of plan benefits. And what that means is for calendar year 2024, not 2023, not 2022, for calendar year 2024, you should be able to know exactly how many physical therapy appointments they will participate in paying for. What, as you say, your copay. What does copay mean? Copay means that every time you're seen, you pay this amount. Every visit, each visit. Deductible is different. Deductible means that before the insurance money will kick in, you have to pay a certain amount. So it could be nothing. It could be $500. It could be $2,000. But for the year 2024, that deductible, whatever that amount is, must be met. Once that amount is met, when you actually have your visits, you pay a copay.
That's right.
Even if the deductible is met. So
Right.
you're still paying. You're going to pay money on top of money. But wouldn't it be great for every person who carries an insurance card to know that on this year and this date, these are the benefits that I have?
Yes. Yes. And they should know that, but they're surprised they don't know that. And when they're told that they have to pay this, it's almost unfair because they're paying their premium, right, at work through their payroll, paying a portion of their premium. And then all of a sudden they have insurance, they get a surgery or they have an injury, they go for their therapy, and now they have to pay for their therapy. And it really has become a burden for patients to stick to their plan of care, which they need, because as you know, the patients that are consistent are the ones that do best.
Correct. In orthopedics, that's where we see the results. We have to be consistent. So these home plans, home therapy plans on the MedBridge platform, obviously that helps in some regards because maybe they could do 2 visits a week instead of 3 visits a week if they're consistent with the platform and they understand the exercises and they're sort of mimicking that provided care that you're able to give in the home environment setting. I neglected to mention because we're just adding so many layers of complexity in this conversation, but patients who used to stay in the hospital for certain surgeries, even ACL surgeries at one point, those were inpatient surgeries where patients would stay overnight and then go home the next day. Total joint replacements, now patients either do those surgeries in ambulatory surgery centers, or they are discharged after a 24-hour stay in the hospital. So, where we used to feel it was essential to get them going with therapy inpatient, staying overnight up to 72 hours, having therapy in the hospital, now patients are going home right away to home care and home physical therapy, having to find a way to make it to your office to be seen. How has that affected the outcomes on your end from joint replacement surgery?
Well, it's interesting. To your point, I remember joint replacement patients being in the hospital for 7 to 10 days or more. Then they were going to subacute centers for
Yes.
rehab, and then we were getting them. And we found out, I think, through the studies, through anecdotal evidence, that it was unnecessary to have that much of a time in a hospital and then in a subacute facility because patients became depressed from being in an environment like that. They became less active because they literally might have an hour of therapy, but they weren't home. They were in a hospital or a subacute facility. They had more risk of falling. They had higher infection rates. So when they started to trim that subacute down and stop doing subacute, and then started trimming the hospital stays down, I found patients did better as long as they got past the surgical risks
Yes.
adequately. And when that was over, they were in our office sometimes within a week and a half, and they were better. The knee replacements were moving their knees better. The hip replacements were walking better because they were active. They were safer. I think the infection rates were less. So we found the outcomes were better with less care.
Wow. Necessity is the mother of
Yes,
invention.
yes, yes.
That's really fascinating that on your end you're seeing those improved results. Now there are patients we've all heard of food deserts where patients live in areas and they're not able to have access to fresh food, to fruits and vegetables. They don't have grocery stores within a walking distance of their residence. Similarly, there are patients who live in physical therapy deserts where they don't have accessible physical therapy. And I have run into someone who is developing a mobile physical therapy platform where therapy comes to them, that there is a van with all of the equipment so that patients aren't necessarily getting substandard therapy. They're getting the same therapy they would get if they were to come to a freestanding building in a mobile platform. Do you see that that would be the future of physical therapy in any way, Carl? What are your thoughts?
So I have two thoughts on that. And I think the first thought, I have to go back to the pandemic. We talked about remote physical therapy, just instructional, watching a patient for years. Then all of a sudden, in a matter of about 4 weeks, we had it. All of a
Yes.
sudden, when the pandemic started, we used a company called PhysiTrack, which was, I think they were from England, and we used their platform. So literally during the pandemic, we did have some patients come in, post-surgical patients, because we were an essential service, so to speak. But we did do remote therapy. My daughter, who's actually a physical therapist, works with a company called Sword, and they are from Portugal, and they provide remote therapy where patients actually put on a couple of sensors so they can actually analyze their movement and give them more real-time, robust advice on what they're doing. I think that platform is going to continue to grow and give us the ability through technology to reach people that can't get out. And I think of seniors who need, 30% of all people over 65 have a fall risk.
Yes.
And then you add other comorbidities with that. So when these seniors are in remote places or can't get out or don't have the support to get out, I think that if technology platforms can become easier to use, say through TV or something like that, I think that's a great potential for people that are stuck home and people that are in areas that can't do it. But mobile physical therapy going around to people where they don't have access to clinics, I haven't heard much about that, but I think it certainly has potential because we have to keep our population moving.
And that's the end of the day, right? At the end of the day, whatever it takes to get people moving and to make sure that they get the care that they need, either in the mobility scenario or in the operative post-operative period scenario. It's very important. And as you mentioned, as the population is aging, then the increased fall risk and the reality of the numbers of fractures that could be occurring will change, I guess, what our primary considerations are in terms of making people safe.
That's right. That's right.
This has been a fascinating conversation. There's one thing that you mentioned that I'll just kind of reframe and rephrase, and I'm wondering if maybe you can shed some light on that. There is a bit of apathy, I think, amongst the American public with regard to healthcare, how it's paid for, what exactly ideal healthcare should look like, and what the exchanges should be between providers and patients. And I'm just wondering, have you given any thought to the psychology behind practices with patients and encouraging patients to sort of comply with the programs that you recommend or play a more active role in their healthcare? Are there any lessons that you've learned over the years with regard to the triggers or the stimuli or maybe even the changes in the way people respond over the years with regard to just the psychology of learning to have a more healthful lifestyle?
Well, yeah, I could talk on that topic forever because I find that, like we've learned in many treatments in medicine, it's got to be precision based to the patient's needs and the patient's beliefs and the patient's motivation to make them compliant. And I think that is a critical thing. If I've learned anything in being a therapist, if you can connect with the patient on what they truly believe and want, not what you think they should do, but what they think they should do, then their compliance, their outcome, their belief in how well they're doing will 100% go along with what their psychology is. For example, we get some patients that are more concerned with not what they're feeling, be it pain or be it whatever, but they're more concerned with what this might be or what this might become. So they just want reassurance and guidance and something to know that they're going to be okay. Where you have other patients that really, they don't have any fear, they don't have any fear avoidance. They just want to get better and they'll work in a different way. Now, neither of those are good or bad. They're just unique to their own individual needs and wants. And our most effective therapists that we work with are the ones that can connect and find that and change the way they interact with those patients. So it's not like I'm the therapist or I'm the doctor, you have to do what I say. I mean, sometimes you do, but it's to get them to the point you want to get them. You can't force that. You have to work with them. And I think that's the one thing that I've learned most about healthcare is that patient compliance is based upon patients' beliefs, desires, and needs.
And when you add the layer of it comes at a price, so it's not just happening in a vacuum. It comes at the price of maybe lost time from work or increased commute time in terms of
Right.
making time in the schedule to come in. Or, as we talked about, the deductible and the copay. The fact that not only are we dealing with sort of the psychology of care, but now we're really, I think, more conscious about the cost associated with that. How does that change things, if at all?
That's a very good point, and let me say this about that point. So our arrival rate in the field of physical therapy, and I'm probably going to speak out of turn here because I don't know the exact number, but I'm going to say it's probably in the low 80s, meaning almost 20% of patients will cancel, right?
Yes.
And I've been hoping and dreaming one day to get a young college student who's in data analysis, right, and put all our data in. And
Yes.
exactly to your point. And in that data, I would put the time of day that the appointment is, their copay, their family situation, their socioeconomic situation, their job hours. And what's the correlation between cancellation and not coming and those factors? Very often it's monetary, it's copay, but sometimes it's just contextual in terms of where they work or what they do. And that is where I think we have the greatest potential to have better outcomes, reach more people, and do a better job.
Yes, I like that. Better outcomes, reach more people, and do a better job. Dr. Gargiulo, you get the last word on this podcast. We sort of covered the gamut, and I hope we have educated our listeners about the current status of physical therapy, some of the solutions that now exist that are available to patients to make physical therapy more accessible, the development of physical therapy and physical therapy practice over the decades that you've been in practice. But of everything that we've spoken about, or even something else, what do you feel the last word should be for our listeners?
I'm just very grateful to have been part of a system that I've seen grow and evolve into a useful tool to keep people active and healthy and independent. I often go around to seniors and I say, some of the senior buildings we go around, we do fall prevention lectures, and I say, what do you value most? And, they might say, well, I value my family, I value my money, or I value, some things I have. And I say to them, but I think the thing you all value most, even above that, is your independence, right? And a lot of that goes with your mobility and your ability to get around and move. So the most gratifying thing that I've seen in my life and career as a physical therapist is how the medical profession, people like yourself, your husband, and great practitioners have realized the value of movement and independence for their patients and supported that in encouraging their patients to go to therapy and motivating them to stay with it. So I'm just happy that we've been part of a profession that has evolved into better care and better independence for patients and our population.
Excellent words of wisdom. And, congratulations, Dr. Gargiulo, for having such a distinguished career that goes back, is it 47 years? Is that
Yes.
right?
Yeah.
That's amazing. What an accomplishment. Kudos to you and
Thank you.
to your family for supporting you in this life work of yours. Just a caveat that Dr. Gargiulo has cared for his community with so much heart and is really known as a bulwark in northern New Jersey when it comes to healthcare for physical therapy care for all patients of all ages. So thank you for your work, for your dedication in your career, and for joining us on another chapter of this podcast, UpMed, a journal of healthcare's race to the bottom. We'll see you next time.
Thank you, Erica. Thanks.
Thank you for listening to this episode of UpMed. For more information on Dr. Erica, visit her website at upmed.us and her LinkedIn profile at Erica Rowe Urquhart. To continue the conversation, visit and subscribe to our YouTube channel at Rowe Urquhart. And don't forget to hit the follow button on your favorite listening platform so you never miss an episode. We look forward to joining you next time on UpMed, a journal of healthcare's race to the bottom.